Welcome to Med School Content, and thanks for joining us on the Disease Management Series. Today we're breaking down inflammatory bowel disease, or IBD, a complex, chronically relapsing condition that affects nearly 2.4 million Americans and is rising globally with urbanization. Whether you're preparing for boards, managing a patient in clinic, or just trying to understand why your attending keeps quizzing you on NOD2 mutations, this deep dive will give you the clinical intuition you need. Let's get started. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Here's the thing about IBD, it's not one disease, it's a spectrum of dysregulated immunity against the gut microbiota, driven by over 240 susceptibility loci scattered across the genome. The prevalence in North America and Europe exceeds 0.3%, with more than 2.39 million Americans diagnosed, and that number keeps climbing as Western lifestyles spread globally. The disease hits hard in young adulthood, peaking between ages 20 and 29, with a second smaller peak appearing in the elderly population between 60 and 90 years old. About 15% of patients land in this gray zone called IBD unclassified, where the features overlap so much you can't confidently call it ulcerative colitis or Crohn's disease. The pathophysiology involves a complex interplay of four factors: genetic susceptibility, microbiome dysbiosis, epithelial barrier defects, and immune dysregulation, all converging to drive chronic inflammation. Key genetic variants include NOD2, which predisposes to fibrostenotic Crohn's disease, and ATG16L1, linked to fistulizing Crohn's. The downstream immune pathways targeted by modern therapies include TNF-alpha, IL-12/23, and JK STAT signaling. Here's a critical board pearl: anti-IL-17 therapy drugs like secukinumab and ixekizumab are actually contraindicated in IBD because they can worsen disease and trigger fulminant flares. Knowing what not to use is just as important as knowing what to use. Let me paint the clinical dichotomy clearly. Ulcerative colitis and Crohn's disease are fundamentally different diseases that happen to cause bowel inflammation, and understanding their distinctions is the backbone of IBD medicine. Ulcerative colitis is confined to the colon and rectum. It always involves the rectum and spreads proximally in a continuous pattern with no skip lesions. Crohn's disease, by contrast, can affect any part of the GI tract from mouth to anus, loves the terminal ileum, and has this signature pattern of skip lesions with normal mucosa interspersed between inflamed segments. When you look at depth, UC stays in the mucosa and submucosa, it doesn't break through the muscularis. Crohn's penetrates transmurally, meaning it involves the full thickness of the bowel wall, which is why fistulas and strictures plague Crohn's patients, but are vanishingly rare in pure ulcerative colitis. Histologically, UC shows crypt abscesses driven by a Th2 response, whereas Crohn's shows non-cascading granulomas with a Th1/Th17 signature, completely different immunologic patterns. On imaging, UC gives you pseudopolyps and that lead pipe appearance from loss of haustral markings, while Crohn's shows cobblestoning, the classic string sign in the terminal ileum from severe narrowing and creeping mesenteric fat. Clinically, UC patients complain of left lower quadrant pain with frequent, small volume bloody diarrhea and tenesmus, whereas Crohn's typically presents with right lower quadrant pain, chronic watery diarrhea, weight loss, and often just occult blood rather than gross bleeding. Serology diverges too. Ulcerative colitis lights up Pianka, Crohn's shows ASCA antibodies. And here's something most textbooks don't emphasize enough: smoking is protective in UC, and many patients actually experience their first flare or worsen after quitting. But in Crohn's, smoking worsens outcomes and increases recurrence after surgery. Ulcerative colitis is a disease of the colonic lining, and understanding its confined anatomy explains why it behaves so differently from Crohn's. The inflammation is strictly limited to the mucosa and submucosa, never breaching the muscularis propria, and it's driven by a Th2-mediated immune response. Grossly, you see a friable, erythematous mucosa studded with pseudopolyps. Those aren't true polyps, but rather islands of regenerated mucosa amid denuded areas. The clinical signature is frequent, small volume bloody diarrhea accompanied by tenesmus, urgency, and left lower quadrant pain that can be debilitating during flares. The Montreal classification divides UC into three categories: E1, proctitis limited to the rectum. E2, left-sided colitis extending to the splenic flexure. And E3, extensive colitis, meaning inflammation extending proximal to the splenic flexure. Here's something that surprises residents. About 10 to 20% of patients with pancolitis develop backwash ileitis, where inflammation spills backward into the terminal ileum, though it rarely extends proximal to that. For severity grading, the S3 definition of severe colitis requires at least 6 bloody stools per day plus systemic signs, pulse greater than or equal to 90, temperature greater than or equal to 37.5 degrees Celsius, hemoglobin less than 10.5, or erythrocyte sedimentation rate, or ESR, greater than or equal to 30. Meeting these thresholds shifts you toward more aggressive inpatient management and biologic therapy. Crohn's disease respects no anatomical boundaries and penetrates deep, explaining the entirely different disease phenotype and why surgery here is never curative. The inflammation is transmural, involving all layers of the bowel wall from mucosa to serosa, which is why patients develop fistulas and strictures, features you almost never see in pure ulcerative colitis. Th1 responses drive the formation of non-cascading granulomas, while Th17 cells orchestrate neutrophilic infiltration that causes the relentless tissue damage. Grossly, you see cobblestone mucosa from islands of ulcerated epithelium separated by edematous ridges, creeping mesenteric fat that encases the bowel, and fibrostenosing strictures that can occlude the lumen. Clinically, Crohn's often masquerades as acute appendicitis, right lower quadrant pain, fever, and systemic symptoms, except the symptoms are chronic, spanning weeks to months. Patients present with chronic watery diarrhea, progressive weight loss, and low-grade fever, but notably, gross hematochezia is less common than in UC. Most of the bleeding is occult. Here's the malabsorption cascade that makes terminal ileum disease so treacherous. Inflammation and surgical resection of the terminal ileum impair vitamin B12 and bile salt absorption, leading to megaloblastic anemia and increased free oxalate in the colon, which then gets absorbed and precipitates as calcium oxalate kidney stones, a perfect storm of complications that patients don't connect until you piece it together. Bile salt malabsorption also promotes cholesterol gallstone formation, because the depleted bile salt pool can no longer keep cholesterol solubilized, and it drives secretory diarrhea through increased colonic camp, perpetuating the symptom burden. The intestines don't live in isolation, and IBD inflammation frequently extends beyond the GI tract in ways that surprise even experienced clinicians. Extraintestinal manifestations, or EIMS, occur in roughly 25 to 40% of IBD patients and sometimes dominate the clinical picture. Musculoskeletal EIMS are the most common. Peripheral arthritis correlates with bowel activity and usually improves with disease control. But axial involvement like sacroiliitis and ankylosing spondylitis follows an independent course and is strongly associated with HLA-B27, meaning it may not improve despite perfect bowel control. Dermatologic EIMS include erythema nodosum, which correlates with disease activity and is more frequent in Crohn's, and pyoderma gangrenosum, a severe necrotizing skin condition seen in 1 to 12% of ulcerative colitis patients that often follows its own trajectory and tragically may not heal even after colectomy. The hepatobiliary link is particularly important. Primary sclerosing cholangitis, or PSC, is strongly associated with ulcerative colitis. Roughly 5% of UC patients have PSC, and conversely, 50 to 75% of patients with PSC have underlying IBD. Critically, PSC does not improve with colectomy, and it independently increases colorectal cancer risk. Ocular involvement like anterior uveitis, iritis, and episcleritis occurs in 1 to 10% of IBD patients and requires urgent ophthalmology referral because untreated uveitis can cause permanent vision loss. Crohn's has unique cutaneous manifestations, particularly perianal disease, fistulas, skin tags, and hemorrhoids afflict about 33% of Crohn's patients and sometimes cause more morbidity than the bowel disease itself, along with oral aphthous ulcers that correlate with disease activity. Modern IBD diagnosis has shifted toward a biomarker-driven approach that reduces unnecessary procedures and triages patients smartly. Start with initial labs ruling out infectious mimickers, Clostridioides difficile, Salmonella, enteroinvasive E. coli, because these masquerade as IBD flares and derail management. Check a complete blood count, or CBC, to characterize the anemia. Iron deficiency predominates in UC from chronic bleeding, while B12 deficiency points toward Crohn's involvement of the terminal ileum. Measure inflammatory markers like C-reactive protein or CRP, and erythrocyte sedimentation rate, or ESR. Here's the game changer from the American Gastroenterological Association 2023 guidelines. Fecal calprotectin below 150 micrograms per gram essentially rules out active mucosal inflammation, and if calprotectin is normal plus fecal lactoferrin is normal plus CRP is normal, you can confidently avoid routine endoscopy and investigate alternative diagnoses. The gold standard remains colonoscopy with mucosal biopsy. Endoscopy shows the depth and extent of inflammation, and histology confirms the diagnosis. But here's the key. A full colonoscopy should ideally wait at least 6 weeks after a severe flare to reduce perforation risk. However, in acute severe colitis, an unprepared flexible sigmoidoscopy is standard of care to assess severity and rule out CMV colitis. UC imaging shows the lead pipe sign from loss of haustra. Crohn's imaging on CT or MR enterography reveals the string sign of a narrowed terminal ileum, bowel wall thickening, and often mesenteric fat stranding. If you're finding this breakdown helpful so far, take a second to hit that like button and subscribe to the channel. It really helps us keep making these deep dives. Now let's get into the part everyone wants to know. How do we actually treat IBD? Treatment paradigms in IBD have undergone a seismic shift over the past decade, moving away from cautious step-up approaches and toward early, aggressive, top-down therapy in moderate to severe disease. The strategic goal is clear: induce and maintain clinical remission, endoscopic remission, and ideally histologic remission, what we call deep remission, because mucosal healing predicts fewer relapses and better long-term outcomes. Glucocorticoids are induction-only agents. They work beautifully to break a flare, but should never be used for maintenance because of cumulative toxicity with long-term use. The step-up approach, starting with 5-aminosalicylic acid, or 5-ASA, or budesonide and escalating only if symptoms persist, is reserved for low-risk patients with mild to moderate, uncomplicated disease. But here's what's changed. The top-down approach is now preferred for patients with moderate to severe disease or high-risk features, age younger than 30, extensive disease, deep mucosal ulcerations, or stricturing or penetrating phenotypes in Crohn's, and current guidelines endorse starting advanced therapies, meaning biologics, early rather than waiting for steroid failure. Therapeutic drug monitoring is crucial. Don't just prescribe infliximab and hope, measure trough levels and anti-drug antibodies to ensure adequate exposure and adjust dosing if loss of response occurs. Mild to moderate IBD management relies on foundational drugs that are safe, effective, and well-tolerated as monotherapy or in combination. The 5-aminosalicylates, particularly mesalamine, deliver the active anti-inflammatory moiety without the sulfonamide side effects that plague sulfasalazine, though sulfasalazine remains relevant if sulfa allergy is ruled out and you need an affordable option. For ulcerative colitis, combining oral mesalamine with rectal mesalamine is more effective than either alone, so don't shy away from enemas and suppositories. Mesalamine is markedly less effective in Crohn's disease, so don't waste time here. Budesonide offers site-specific delivery. The UC formulation, brand names Euceris or MMX, releases in the colon and is given at 9 mg daily for 8 weeks without taper. Patients tolerate it well because systemic absorption is minimal. The Crohn's formulation, Endocort, releases in the terminal ileum and ileal colon, also at 9 mg daily, but here's the critical difference. It's used at full dose for 2 to 3 months and then tapered down to avoid rebound symptoms. Immunomodulators like azathioprine and 6-mercaptopurine take weeks to work, so they're used for maintenance rather than induction. But here's the absolute board pearl. Always check thiopurine methyltransferase, or TPMT, activity before prescribing thiopurines because about 1 in 300 people lack the enzyme entirely and will develop severe, life-threatening myelosuppression on standard doses. Methotrexate works for Crohn's maintenance but is teratogenic and requires folate supplementation. Advanced therapies mean biologics and small molecules that target specific immune pathways with remarkable precision and efficacy. Anti-tumor necrosis factor, or anti-TNF, agents dominate. Infliximab is given intravenously, penetrates well into fistulous tissues, and is the gold standard for fistulizing Crohn's disease. Adalimumab is subcutaneous, works in both UC and CD, and has excellent patient adherence. Certolizumab pegol is exclusive to Crohn's. Golimumab is UC only. Anti-integrin therapy with vedolizumab targets the gut-selective alpha-4 beta-7 integrin and was superior to adalimumab for first-line induction in the Varsity trial for ulcerative colitis. It's gut-selective, meaning fewer systemic infections than non-selective anti-integrins. Natalizumab is rarely used now because of progressive multifocal leukoencephalopathy, or PML, risk from JC virus reactivation. Anti-IL-12 and IL-23 biologics represent the frontier. Ustekinumab was non-inferior to adalimumab in bio-naive Crohn's disease in the Seaview trial and is increasingly first-line. Risankizumab, which specifically targets IL-23, earned approval for both UC and CD based on clinical trials such as Advance and Motivate for Crohn's and Inspire and Command for UC. Guselkumab and mirikizumab are approved for ulcerative colitis. Small molecules are emerging as attractive options. JAK inhibitors like tafasitamab are approved for UC and upadacitinib for both UC and CD, but they carry risks of venous thromboembolism and herpes zoster reactivation, so use them cautiously in high-risk patients. Sphingosine 1-phosphate, or S1P, receptor modulators like ozanimod and etrasimod are approved for UC and offer convenient oral dosing. Acute severe ulcerative colitis is a medical emergency that demands recognition and rapid escalation to prevent catastrophe. Toxic megacolon, the nightmare scenario, is defined by transverse or right colon dilatation exceeding 6 cm on imaging, coupled with loss of haustral markings and signs of systemic toxicity like fever, tachycardia, and leukocytosis. If perforation occurs, mortality approaches 15%, so you cannot be cavalier. Medical rescue therapy demands intensive monitoring in an ICU setting with aggressive IV methylprednisolone, meticulous fluid and electrolyte replacement, and broad-spectrum antibiotics. If the patient doesn't improve within 3 to 5 days on maximal IV corticosteroids, per the Oxford criteria, typically reassessed at 72 hours, escalate to rescue therapy. IV infliximab or IV cyclosporine can salvage the situation, but if there's still no response, urgent colectomy is mandatory. Here's the critical board pearl that saves lives. Antiperistaltic agents like loperamide, diphenoxylate, and opioids are absolutely contraindicated in acute severe colitis because they precipitate or catastrophically worsen toxic megacolon by impairing propulsive contractions and allowing toxic products to accumulate. If a patient is admitted with bloody diarrhea and you see they took loperamide, that's red flag territory. Surgery in IBD serves different purposes depending on whether you're treating ulcerative colitis or Crohn's disease. For ulcerative colitis, restorative proctocolectomy with allele pouch anal anastomosis, the IPAA or J-pouch operation, is curative because you remove the entire diseased colon and rectum, and the patient's own small bowel is fashioned into a neoreservoir that maintains continence and avoids permanent ileostomy. Pouchitis, inflammation of the newly created pouch, develops in 30 to 50% of patients, usually responds beautifully to antibiotics like ciprofloxacin and metronidazole, though about 3 to 5% develop refractory pouchitis that's genuinely difficult to manage. In emergent settings where you need to control toxic megacolon or massive hemorrhage, you perform subtotal colectomy with end ileostomy, leaving the rectal stump in place so you can restore continuity with a J-pouch later once the patient stabilizes. Crohn's disease surgery is fundamentally different. Surgery is never curative because Crohn's is a transmural panenteric disease and inflammation recurs at anastomosis sites in up to 80% of patients. So the surgical philosophy here is bowel sparing. Perform limited resection only for the diseased segment, not wide margins. Strictureplasty, opening the stricture longitudinally and closing it transversely, preserves bowel length and prevents the short bowel syndrome that devastates patients with multiple resections. Indications for surgery in Crohn's are specific: intractable bowel obstruction from strictures unresponsive to medical therapy, refractory fistulas with abscess drainage, and frank perforation. Chronic inflammation in IBD sets the stage for serious long-term complications, and colorectal cancer surveillance is arguably the most critical conversation you'll have with a patient. Colorectal cancer risk increases dramatically with disease duration exceeding 10 years. With disease extent, pancreatitis carries higher risk than left-sided disease, and with severity of inflammation, particularly frequent severe flares. Surveillance colonoscopy should begin at 8 years after disease onset and then every 1 to 2 years depending on risk stratification, with careful attention to dysplasia detection. Here's the absolute rule. Any flat high-grade dysplasia, even if it's a single lesion, mandates colectomy because progression to invasive carcinoma is nearly inevitable. Ulcerative colitis complications beyond cancer include massive hemorrhage, rare but life-threatening, occurring in about 1% of patients, colonic strictures in roughly 5% that can mimic malignancy and always require endoscopic investigation, and chronic iron deficiency anemia from blood loss. Crohn's disease complications are a constellation of bowel obstruction from strictures in 4 to 16% of patients, fistulizing disease including enterovesical fistulas that cause pneumaturia and fecaluria, abdominal abscesses requiring drainage, frank perforation, and the long-term specter of short bowel syndrome after multiple resections. Pregnancy and vaccination are situations where patient counseling prevents catastrophe and requires nuance. Here's the rule. Active IBD is far more dangerous to the fetus than most medications. So you absolutely must not allow patients to stop effective therapy in hopes of protecting pregnancy, maintain remission, and the baby does better. The 5 amino salicylates are safe throughout pregnancy with folate supplementation. Thiopurines are safe, though counsel patients about the long-term data. Anti-TNF agents are safe in pregnancy, though some transplacental passage occurs. Methotrexate is teratogenic and category X, absolutely contraindicated. JAK inhibitors like defacitinib and upadacitinib should be avoided in pregnancy based on animal and limited human data. For vaccination, the strategy is simple. Complete all age-appropriate vaccinations including hepatitis B, pneumococcal, and others before starting immunosuppressive therapy because the immune response will be blunted once on biologics or immunomodulators. Live vaccines, measles, mumps, rubella, or MMR, varicella, live zoster, live influenza, are absolutely contraindicated once patients are on biologics or immunomodulators because the attenuated virus can disseminate and cause disease. Let me hit the high-yield pearls you need to lock in for boards and clinical practice. The dichotomy. Ulcerative colitis is continuous colonic inflammation with pseudopolyps and P. serology. Crohn's is transmural, skip lesion disease with granulomas and ASCA antibodies. Smoking protects UC but worsens Crohn's, a counterintuitive gem. Fecal calprotectin below 150 micrograms per gram rules out active inflammation. Anti-IL-17 therapy is contraindicated in IBD. Anti-peristaltic agents precipitate toxic megacolon, that's lethal territory. Methotrexate is teratogenic and absolutely forbidden in pregnancy. Thiopurines require TPMT testing before prescribing. Surgery is curative for UC via J-pouch, but never curative for Crohn's. Instead, use strictureplasty to preserve bowel. Colorectal cancer surveillance starts at 8 years of disease, but risk truly escalates after 10 years, screen every 1 to 2 years. These distinctions separate the prepared clinician from the median one. Thanks so much for watching. If this breakdown helped you understand IBD a little better, please hit the like button, subscribe to the channel, and ring the notification bell so you don't miss future videos in the disease management series. Leave a comment below with questions, cases you've seen, or topics you want us to cover next. I read every single one. This is med school content, and I'll see you in the next one.